Hello everybody, my name is Christian Schmid. I'm a Chief of Service and lecturer at the University Heart Center in Zurich, Switzerland, and I'd like to talk to you about cardiovascular prevention. Benjamin Franklin once said, "An ounce of prevention is worth a pound of cure," and he was so right, and I want to show you that. We know that there are a certain amount of cardiovascular risk factors. On one point, there are not influenceable risk factors as age, gender, the male gender at least, and family history, so the genetic burden. But there are 8 or 9, it depends on the matter how you count, for influenceable risk factors which can really target on. It's dyslipidemia, so hypercholesterolemia. It's diabetes mellitus. It's obesity, let's say overweight or an increased waist circumference. It's smoking, sedentarity, poor nutrition, negative stress, and last but not least, hypertension. The famous Interheart study pointed one important thing out. The 9 influenceable cardiovascular risk factors are responsible for the vast majority, 90 to 95, of all myocardial infarctions. So on the other hand, if we could target all of these 9 risk factors, we could really decrease the burden of mortality of the general population of cardiovascular disease. And it's not just one risk factor we should address. It's the aim of a healthy way of life. So if we address one positive factor as non-smoking or healthy nutrition or exercise, we have really a massive decrease of cardiovascular disease burden. But if we combine all 3 of them, we have even more massive decrease. And on the other hand, we know that smoking, diabetes, hypertension and dyslipidemia all for themselves show a massive increase of cardiovascular risk. But if we provide and target all of them, we could really have a major impact on cardiovascular risk. So let's go through all these 9 or 8 influenceable risk factors. And I want to start off with 3 of them, which you can put together kind of in the so-called metabolic syndrome. It's dyslipidemia, diabetes, and overweight, respectively, waist circumference increase. We know regarding dyslipidemia that it's really all about the lower the better. So we know from various data, and you see different studies in this graph here, that in secondary prevention, but as well in primary prevention, the lower the LDL cholesterol is, the better the outcome. The cardiovascular events are less, the lower the LDL cholesterol is. And we can reach that with drug therapy and also with lifestyle changes. What are the targets? As I said, it's mainly the LDL cholesterol, but we have other targets in cholesterol subgroups which we should focus on. One should consider an LDL cholesterol in secondary prevention of less than 1.8 millimole per liter. That's the main target, I would say. And we can reach that, we can achieve that with drug interventions as well as lifestyle interventions. The major drugs, you might know them, are the statins, the selective cholesterol resorption inhibitors called ezetimibe, and the newer group, the so-called PCSK9 inhibitors. Very potent medication, very potent drugs with a lot of beneficial effects on cholesterol and cardiovascular outcome. Lifestyle interventions mainly consist of nutritive interventions, although the effects are pretty poor over there. We have some good data on functional food, and moderate alcohol might have some beneficial effects as well. Diabetes mellitus is also an important cardiovascular risk factor, of course, being part of the metabolic syndrome. And there's a multifactorial approach in therapy. Of course, glucose control is in the first line. We have metformin and we have the empagliflozin as well that also shows a reduction in cardiovascular death. Lipid control, as I just said, provided by various medication, and it's also important to have an eye on blood pressure control on these diabetics. We mainly use the so-called ACE inhibitors, and the target is slightly lower than in a normal population. It's less than 130 to 140 to 80 to 85 millimeter mercury. The relation between diabetes and obesity is obvious, and it's impressively shown in this graph showing the local distribution in the USA. And we see also a massive increase of both entities during the decade. So the correlation is clear, and as such we should also target within the metabolic syndrome the obesity. And it has been shown in recent data that waist circumference, so an increased waist circumference, is the much more risk factor to target on than the weight or the body mass index. As you see in the graph, even if you have a high body mass index but a low waist circumference, your risk may be lower. And on the other hand, once your waist circumference is increased, although you have quite a low body mass index, you have a massively increased cardiovascular risk. So waist circumference nowadays is the right target when targeting the risk factor of obesity. Moving on to the next risk factor, it's smoking. Smoking is probably the most cost-effective risk factor once you skipped smoking at least. And there are some facts and figures I want to point out. Life expectancy is massively reduced in smokers 11 to 12 years overall. The risk for myocardial infarction is increased by a factor of 2 to 3. At least there's no safe way for nicotine intake. So whether you smoke cigarettes or pipes or chew nicotine, it's all bad for your cardiovascular system. There's no safe amount of cigarettes per day. Of course, it's better to smoke just one cigarette compared to 20 cigarettes, but after one cigarette, the risk is also increased. And finally, there are still poor statistics regarding willingness to stop. So there's still a lot of need in regarding preventive measures regarding this important risk factor here. And there are some pitfalls in nicotine cessation. Obviously, there's the withdrawal syndrome, so patients should be clarified and substitution therapy should be provided. The recurrence and failure should be obviously also communicated to the patients. At least 5 tries are possible at an average to become an ex-smoker. So there's a learning process as well. The environment is of course important, the stress level from the environment. So choose, if it's possible, a favorable moment and integrate the environment and other smokers in the family or surrounding of the patients. And there's an expected weight gain in approximately 80%, and patients have to be aware of that fact. Generally, there are the 5 A's for smoking cessations which we should be aware of. So it's all a multifactorial approach. So first, we need an efficient patient, of course. We need some pharmacological support at a certain point. We need a behavioral therapy. And last but not least, also professional guidance to provide an efficient smoking cessation in the end. The next cardiovascular risk factors are again 2, because I want to put them together. It's sedentarity and poor nutrition. So both go together, and that's important. It's always a corporate approach, and only the corporate approach is beneficial. So there's no specific sport, no specific intensity, no specific percentage of a certain nutrition or energy suppliers. It's together. And I want to show you that in a few slides, which I want to show you right now. So only the corporate approach is shown particularly in patients that only train really hard. So in the first place, there's really an additive effect. So we have really an increased calorie expenditure. But time after time, the body adapts on that. So the aim of the body is to save energy and not to lose energy and weight. So after some point, the basal metabolism is decreasing, and so the training effect is also decreasing. It's also the same with nutrition and diet. So it's important to follow that corporate strategy over there. And particularly nutrition, it's important to mention that the recent recommendation going for about 50 to 60% of carbohydrates, 30% fat, and about 8 to 11% proteins. Right, just for the cardiovascular point of view, it's more important to adapt that a little bit. So we go for a little fewer carbohydrates, let's say 30 to 40 unit percent. A little more fat is allowed regarding the cardiovascular point, and also a little more proteins may be allowed for cardiovascular prevention. So the so-called Mediterranean diet is one perfect match, and up to 40% fat as nutrition is integrated in that concept. It's highly significant. It shows highly significant benefits in major cardiovascular outcomes as cardiovascular death, non-fatal myocardial infarction, unstable angina pectoris, stroke, heart failure, and so on. So I think this is really a concept we highly recommend for our cardiovascular patients, the Mediterranean diet. Further cardiovascular risk factors is negative stress, and probably this factor is the most underestimated, but nevertheless most important cardiovascular risk factor lately. So negative stress is clearly associated and an important cardiovascular risk factor globally. Depressive disease is well known. Depressive symptoms, panic or anxiety disorders double or triple the cardiovascular risk. Furthermore, psychiatric disease is an independent risk factor for medication malcompliance, which is also an important point, of course. And coming back to the INTERHEART study, it has been shown that patients with myocardial infarction show a massively increased appearance of the 4 major stress factors, as they are stress at work, at home, financial stress, and major life events in the past year. So this is really important. On the other hand, we also know that positive affections may improve cardiovascular risk. It's nicely shown with animals, so generally in the animal world, let's say, we know that the higher your heart rate per minute is, the less your life expectancy appears. So we know that mice or rats, which exhibit a very high heart rate per minute, have a life expectancy of only a few years, let's say month. But on the other hand, like whales, which with a very low heart rate, they show very high life expectancy, depending on the heart rate and also as an indirect surrogate marker for stress. Coming finally to the last but not least very important and also underestimated risk factor of hypertension. It's a major risk factor but frequently undetected. As I said, approximately 50% of the 50 years old are hypertensive. Approximately 9.4 million deaths yearly and 7% of the global so-called disability-adjusted life years are due to hypertension, mostly undetected. There are a lot of very nice drug interventions that are possible. We can really reduce the risk of cardiovascular disease by diuretics, calcium antagonists, ACE inhibitors and ARBs, and beta blockers, which are the first-line therapy in coronary heart disease. Others are alpha blockers and aldosterone receptor blockers. A combination of at least 2 drugs leads to a relevantly more effective lowering than doubling the dose of a single drug. Lifestyle interventions are important as well, so it's about weight control, nutritive aspects as restriction of alcohol intake, regular exercise and reduced salt intake. A general target can be seen approximately 130 to 140 systolic and 80 to 90 millimeter mercury diastolic values. The recent SPRINT trial suggests lower target values, but however, the results are debatable in certain subgroups, and of course, it's impossible to make a conclusive impact on the general guidelines from this trial on. So let me conclude on cardiovascular prevention. Modifying influenceable cardiovascular risk factors pharmacologically and by lifestyle changes is the major aim in secondary and primary prevention. The positive affection of every single cardiovascular risk factor is important, but to target all of them by following a healthy lifestyle leads to a massively improved outcome. I thank you very much for your attendance, and I wish you a nice day.